Good day, everyone. Today we'll be talking about handling liver biopsies in routine surgical pathology practice. The liver is the second largest organ in the body and is important in most of our daily body processes. As a result, it can be afflicted with different diseases. Some may be medical, while others may be surgical, requiring excision. An adequate histologic diagnosis is required to be able to treat or manage the various diseases of the liver. Consequent to this, daily surgical pathology practice involves handling various types of liver biopsies for suspected medical conditions, ranging from hepatitis to benign and malignant neoplastic diseases. Benign neoplasms could include focal nodular hyperplasia or adenomas, while malignant neoplasms include hepatocellular carcinomas, metastatic tumor deposits, or cholangiocarcinomas. The samples received could range from needle biopsies to liver resections, for example, in the case of a transplant. These samples usually go through various ancillary tests, which include or could include histochemical and immunohistochemical stains, in addition to our routine H&E stains. At every time, it is important to note that any diagnosis rendered, for example in the case of malignancies, will require specific staging information for adequate treatment and prognosis. So, on receiving the liver biopsy in the lab, a few things should be noted or considered. First, has the biopsy been received fresh, or has it been placed in a fixative? If it has been placed in a fixative, what type of fixative was used? Is it formalin or non-formalin based? Some special fixatives like glutaraldehyde may be required for special studies like electron microscopy. The nature of the disease or procedure being done may require examination of fresh tissue. Thus, a frozen section may be done for intraoperative consultation, where a timely feedback is required by the surgeon. A touch imprint cytology is also another way of examining fresh tissue. Fresh tissue could also be sent for microbiological culture and sensitivity when infectious diseases are suspected. Most times, liver tissue, when received fresh, is divided with some fragments placed in fixatives for further processing, while the remaining fresh tissue is used for frozen sections or touch imprint cytology as the case necessitates. Additional tests that may be done may include flow cytometry, cytogenetics, and molecular profiling. In the latter scenario, fresh tissue is placed in alcohol-based fixatives, as formalin, if used, will be associated with poor recovery of nucleic acids. The part of the biopsy fixed in formalin undergoes routine processing for H&E staining and for histochemical stains like iron, reticulin, and elastic tissue. The nature of the tests carried out depend on the nature of the disease condition, or it could also depend if the tissue is being used for research or a clinical trial is being undertaken. The first image shows a resected, enlarged, diseased liver. The gleaming capsular surface has been breached by multiple grayish-white tumors. The anatomy is partly distorted by these nodular masses. The second image shows an apparently unremarkable liver tissue with the gleaming capsule intact, while the third image shows a shrunken cirrhotic liver with multiple micronodules. Orientation markers provided by the surgeon may include sutures, ligatures, or incisions. It is necessary to photograph the specimen, then go ahead to identify the nature and type of sample based on the procedure carried out by the surgeon. For example, it could be a segmental resection with all the segments recorded, a wedge resection, partial hepatectomy, or a total hepatectomy. The dimensions of the sample should also be taken in 3 dimensions, i.e. anterior-posterior, mediolateral, and superior inferior, or simply stated length, breadth, and width. All anatomical components present should always be described. For example, if the gallbladder is present, it should be documented along with its dimensions. Gallbladders have a separate or specific protocol for grossing, which will be discussed in another series. The length and diameter of the common hepatic ducts, hepatic duct bifurcation, left and right hepatic ducts, as well as the cystic ducts should be noted. So next up is the weight of the liver, which is usually documented in grams. Subsequently, the liver capsule should then be examined. This should be examined to determine if it is intact or normal, breached by tumor nodules, or stained by pigment, or you might want to be assessed for the presence of scar or sutures, which may indicate a previous history of surgery. Lastly, the integrity of the specimen should be described with regards to consistency, friability, fragmentation, etc. Next comes the fun part, which is dissection of the sample. The samples are usually sectioned perpendicularly to the parenchymal resection plane. This facilitates correlation with radiology where possible and when necessary. Some huge masses may require extended fixation of their cut slices in formalin. The cut surfaces may show a variegated appearance, ranging from hemorrhagic, jaundice-tinged liver surfaces to relatively circumscribed nodular masses. All the surgical margins should be inked appropriately with various colors when necessary. It could be blue, yellow, as the case may be, at the discretion of the dissector. All cut slices should be photographed appropriately, and all photographs should have or should capture the described features. The cut surface of the liver is then inspected for the presence or absence of tumor. In the example presented, we see a cut section of the liver with a relatively circumscribed nodular mass, which takes up most of the liver parenchymal surface area. The mass appears cystic and gelatinous, with multifocal areas of hemorrhage within the background liver parenchyma. In the second example presented, the cut surface of the liver reveals a greenish, well-circumscribed hard mass. The distance of the capsular surface closest to the tumor should always be measured, preferably in millimeters. This represents the capsular margin. In addition, the distance of the tumor closest to the resection margin should also be measured. This represents the resection margin. Any macroscopic involvement of attached vessels should be noted and described. Any tumor seen should be described in its maximum dimensions, i.e. the length, breadth, and the width. The presence of satellite tumors should also be noted and described. Next is the description of the background parenchyma of the liver. The parenchyma should be noted to be normal, abnormal, or mixed. Curious questions to note are if there are areas of cirrhosis, fibrosis, fatty change, or chronic congestion, which will present as a nutmeg appearance. Occasionally, lymph nodes may be harvested from hepatectomy samples. When lymph nodes are present or when they are retrieved, the region from which they are retrieved or harvested should be described appropriately. The numbers of lymph nodes received should also be noted, along with their individual sizes, usually measured in 3 dimensions. Attention should be paid to the maximum diameter of each of the lymph nodes. It is important to note that each lymph node is separated. Lastly, we come to the processing of the tissue samples. After the specimen has been dissected or after it has been appropriately biopsied, each of the biopsied segments are separated and separately kept within tissue cassettes. Each cassette is appropriately labeled and indicates where the sample or the biopsy was taken from. Samples are taken from the tumor, from the parenchyma, from the resection margins, and from lymph nodes where available or where possible. Each of these cassettes should be recorded appropriately and given specific codes. The codes designate the area the biopsy is taken from. The codes could be in alphabets or it could be in figures. An example could be cassette A, which represents the vascular margin with the hilar vessels. It could be cassette B, showing the tumor and the closest surgical margin. It could be cassette C to D, which show the tumor full face. It could be only cassette E, which shows the tumor interface with the background liver. Cassette F, which shows the tumor closest to the capsule. Cassette G, which shows the background liver parenchyma. And cassette H, which shows the lymph nodes. Alternatively, it could be renumbered as cassettes 1 to 8, where 1 could present the vascular margin, hilar vessels, or shaved section. The numbering of the cassettes should be ordered and usually at the discretion of the dissector. Thank you.